Morning. Thank you for inviting me to this conference. It's always a pleasure to be invited to these types of conferences, international conferences, because you come from across the borders, different countries, with one passion, nursing and patient care. And somehow there's always a kind of energy which is absolutely inspiring. So thank you for letting me come here. I've been asked to talk about fundamentals of care. The title is Fundamentals of Care, Do We Need to Refocus? Some of you might think, oh, fundamentals of care, haven't we heard about that before? We have. Florence Nightingale, Virginia Henderson, and many others. But for some reason, it keeps on popping up the need to actually discuss what is fundamentals of care. At least with different research groups and part of hospitals that have taken this discussion in Denmark about do we need to rediscuss what fundamentals of care is at this point of time. So, what is fundamental nursing care? I think most of us will probably say, I know what it is. I've been educated, I've been trained to deliver fundamental of care to my patients. For years, I've been providing fundamental care to my patients. But if you look at the lovely person next to you, what's the chance that you define fundamentals of care in exactly the same way? You come from different nations, across borders, different countries. Do you have the same understanding in this room of what fundamental of care is? If you do not have the same understanding, is that equal to that you don't provide the same care to your patients? Patients who actually have the same diagnosis? Patients who are admitted to hospitals for the same thing? And does it matter if we define fundamentals of care differently? Is it of any importance that we have conceptual clarity on what fundamentals of care is? Before digging deeper into conceptual clarity of the fundamentals of care, I have two stories. Two stories written by patients. They're extracts written by patients and published in daily Danish newspapers this spring. The first story is written by Preben, a 55-year-old university professor who recently underwent gastrosurgery due to cancer and was given a stoma. The title, Deeply Thankful. I met at the hospital at 6 in the morning. I was greeted by a soothing smile and instructions. I changed into patient clothing, white surgery clothes with long white compression stockings. After a short wait, I was escorted to the operating theatre. On my way to surgery, nervousness rose. But I was met by friendly and accommodating, smiling, green-dressed operating staff. I walked calmly, but scared, to the operating table. Then it went fast. The staff instantly registered my anxiety. They held my hand, spoke comforting words, asked about my daily life, and said that they would take good care of me. The mask came on, completely gone in an instant. 10 hours later, a friendly voice calls my name. 2.5 hours after the operation, I was moved into a room with 3 other patients, both men and women. The next 2 days is an ordeal. Patients go in and patients go out, and they're all ill. It gives cause for unrest. In addition, There's the loss of control of basic bodily functions, such as standing up straight by yourself, walking, drinking, eating, and going to the toilet. The care, the communication, the cheer, and professionalism among the staff is constantly at its highest level, 24 hours a day. After 2 days, I'm totally exhausted by lack of sleep and rest. It is registered. The staff's professional judgment sets in. Quickly and caring, they provided medication and a single room where I got some rest. Miracle sets in. I'm back in control of my own life, and I get discharged. A feeling of happiness with no equal. The second story was written by a young girl, 19 of age, who was admitted to hospital with inflammation of the kidneys and a sepsis. Imagine you smell a 4-day-old sweat and the strange, sterile smell you connect with hospitals. The nurse hands me a towel and some clean clothes. But what difference does it make when I can't even get out of bed? You feel repulsing and can't endure being in your own body. You long for a bath, water that hits your skin and rinses dirt off. Your sister has promised to visit you after breakfast, so you consider your options. What is most humiliating? To lie dirty and sweaty in your dirty linens, or being bathed by your sister? You choose the last option, for in the end, you'd rather prefer to feel good in your body and humiliated than uncomfortable and humiliated. Had the staff had time and resources, they may have given me a helping hand, a hand I desperately needed, because I was so ill that I almost couldn't get out of bed. I was so ill that I couldn't manage to eat. I was so ill that I had to ask my sister to help me with a bath, because I hadn't showered for 4 days. Humiliated, naked, and wet, I sat on a bench in a shower in a hospital, while my sister, who felt just as uncomfortable, washed my hair and dirty body because I didn't get the help from the staff. Do you recognize these stories? I believe most of us in here do. We've either seen them around us, or we're an active part of them. The first story by Prayton, reassures us, tells us that we managed to see the individual, the person, the Prayton, and met his needs for nursing in a professional way. With many of these stories, that's why we get chocolate, flowers, thankful words from patients and relatives. The story by the young lady makes us uncomfortable. Questions pop up. What went wrong? Who was responsible? Could have been done differently. Sadly, this isn't the only story that makes us feel uncomfortable. Research has looked at the delivery of nursing care. One research team has looked at the prevalence, patterns, and predictors of nursing care left undone. This is a European study similar to studies, and similar studies exist from other continents and nations, and the results don't differ much. The study's aim was partly to describe the prevalence of patterns of nursing care left undone in hospitals across 12 European countries. So nursing care that should have been given, but for some reason wasn't. Across the European hospitals, the most frequent nursing care activities left undone included comfort and talk with patients. It's reported 53%. Developing or updating nursing care plans and care pathways, 42%. And educating patients and families, 41%. The tasks given most attention were task-oriented care, such as treatments and procedures, pain management, and administration of medication. In nursing, we have to prioritize. This doesn't come as a surprise and is a necessity in the context of the modern healthcare system. However, what is thought-provoking in this study is that care tasks that actually seem to be a prerequisite to other care tasks seem to be neglected. How do we individually adapt pain management if we don't talk to the patients? How can we plan a person-centered care plan if we don't prioritize time to talk to the patients and relatives? A physician by the name Harlan Krumholtz published an article in New England Journal of Medicine, 2013, describing what he called the post-hospital syndrome. How might the post-hospital syndrome emerge? Hospitalized patients are not only enduring acute illness, which can markedly perturb physiological systems, but are experiencing substantial stress. During hospitalization, patients are commonly deprived of sleep, experience disruption of normal cardiac rhythm, are nourished poorly, have pain and discomfort, confront a baffling array of mentally challenging situations, receive medications that can alter cognition and physical function, and become deconditioned by bed rest or inactivity. If you look at the concepts marked in red, you will think those care needs the nurse has a responsibility to address. On the one hand, this article, in the finest way, addresses the importance of looking and addressing the fundamentals of care among patients. But on the other hand, it highlights that nurses do not, or are not always able to address these needs. This brings me back to fundamentals of care. And what is fundamentals of care? Do we need to rediscuss, redefine? Is that where we see care left out? Because we've forgotten what the fundamental of care actually is. What is it that we as nurses are good at? Recently, this question has been posed by a group of nursing researchers, clinicians, and leaders across the world, led by Alison Kitson. They work together in a research network called International Learning Collaborative. They've posed the question: if we, as a profession, actually need to reconceptualize what nursing is in order to regain a focus on what fundamental of care needs are. The International Learning Collaborative is an international network bringing people together to improve the delivery of fundamental care in healthcare systems. It is done by mapping challenges to delivery of safe, high-quality fundamental of care, conducting international research on the delivery of the fundamental of care, and sharing best available evidence on fundamental care. The ILC is committed to developing and implementing the best available research evidence on fundamental care. Key to this work is developing agreement on a definition for fundamental care and the activities that constitute such care. The fundamentals of care framework is a key catalyst in achieving this goal. When we look at the definition, it says fundamental care involves actions on the part of the nurse that respects and focus on a person's essential needs to ensure their physical and psychosocial well-being. These needs are met by developing a positive and trusting relationship with the person being cared for, as well as their family. On the base of a narrative review, on the base on ongoing research and validation, the research group, has developed a framework called the Conceptual Fundamentals of Care Framework. The framework consists of 3 dimensions: establishing relationship, integration of care, and context of care. This was the first edition of the framework. The edition has changed a little. The reason why there are different editions and they keep on changing is that they keep on being updated so they correspond to what nursing requires at this moment of time based on research. It's 3 concentric interacting circles with a lot of concepts, with a lot of elements inside. They're words. And it's important that you hear that I call it a framework. I'm not calling it a model. I'm not calling it a theory. I'm not calling it a philosophy. It's a framework. The reason why it's a framework is that it's 3 circles with a lot of words inside. And the words, the concepts, they don't tell us what to do, but they remind us as nurses what patient care as a minimum requires. It's based around a central core: relationship established. And there's a reason why it's the core. Establishing a relationship between nurse and patient is a prerequisite for meeting patients' care needs. This is the core blown up. 5 central words: to focus, to know, to trust, to anticipate, and to evaluate. The nurse is committed to establish a relationship with the patient, to get an insight into who is this person that stands across me. How can I help this person the best possible way? The words inside him and the questions that are posed are based on research where they've actually asked patients, what do you expect from a nurse and what do you need from a nurse? So it's the patient's perspective which is mirrored here. Patients would actually like us to ask, what help do you need? And what can you do for yourself? Because I'm not the same patient as the patients next to me. I don't have the same needs. Although I have the same diagnosis, I don't have the same needs. I don't have the same worries. So please do ask me, what can I do for myself? And what do I think I need help with? The 5 central words, concept: focus, know, trust, anticipate, evaluate. Words. They don't tell us anything about how to establish trust. The framework doesn't tell us that. That's where evidence comes in. That's where research, philosophies, theories come in. That's where some of your work today comes in. How to establish a trustful relationship with patients, with your patients, in their situation, in their age group. When the relationship is established, you can move further on to the middle circle. In the middle circle, you've got 3 themes. You've got the psychosocial, the physical, and the relational. Those 3 themes appeared when they made quite a few interviews of patients, and they analyzed the data. And they could see 3 overall themes popped up that patients actually expected as a minimum that the nurse addressed. So they expect you to address physical needs. That doesn't come as a surprise for us. They expect psychosocial needs, and they expect the relational needs. When we think back of the two stories, I think we can already now pinpoint what needs wasn't met with the two patients and what were met, what did go really well. Again, these are just words. So how do we keep a patient hydrated? How do you keep your patients hydrated? I haven't been all the way through all your posters, but there might be a poster about hydration. There might be a poster about, I'm absolutely sure there is, mobilization. How do we mobilize our patients? That's where we need the evidence. What this framework does is that it reminds us, as a nurse, you have to make sure that you have been through all themes and checked, is there anything about hydration with this patient? Nope, not today. Anything about nourishment? Yes, there is actually. He doesn't really eat anything. Is there anything about coping? Do we need to support this patient in coping this situation? So, framework reminds us, and it gives us a mirror, actually, of what research says nursing is, but also what patients tell us this is what we expect from you as nurses. The outer circle is the context of care. This has been quite important because you could actually just leave it to the first two, where they say, it's not a limbo that we work in. We're actually quite restricted in the healthcare systems that we work. We also have possibilities. Those possibilities and restrictions, they affect the way that we are able to meet patients' care needs. It says, a patient say, please listen to, see me, see who I am. Try and establish a trustful relationship. Make sure that I feel safe and trustful. But if you've got a system level, an organizational level, where we meet the patients for 4 minutes, how do we do that? And it's not just 4 minutes where we can choose what we want to do. It's 4 minutes where we have to check. We'll probably have a checklist. We have to measure different things and ask quite specifically about different things. How do we do that? And is that possible? Sometimes we'll have to say we can't do anything. Political level. We have to reach for the politicians, maybe. If it's the system level, we could go back and say, you know what, we know through research that it's very important for patients actually that we establish a trustful relationship between nurse and patient. I'm not able to do that within 3.5 minutes. Is it possible to do it differently? So what this outer circle is supposed to do is, one, to mirror that we have possibilities, but we also have restrictions. What are those possibilities and what are those restrictions? And are they something we should do something about? Do we have a responsibility? Or can we just sit down and say, that's the context, can't do much about that? Or do we actually have a responsibility? So, this framework may be one way to reconceptualize the value and fundamentals of care as it looks now, and develop the evidence base behind the fundamentals of care, and create a greater role clarification of what is needed from us as nurses. When I'm out and I'm talking about this subject, sometimes I've got a few nurses says, well, you know, in Danish you say, this is old wine on new bottles. You've already heard this before. There's nothing new about it. Why are you here? You could say it's old wine and new bottles. But what's wrong with that? What's wrong when drawing forward something we might sometimes have forgotten a little? In this case, it's described a little differently in a framework. And it pinpoints out the importance of the interaction between the patient and the nurse. And it pinpoints on the top, it says, the nurse and the patient are in a relationship where the patient is dependent of the nurse. That's why they're in contact with each other. The nurse's job is to make the patient as independent as possible. Fundamentals of care. This is the newest version. And you'll find that on ILC's homepage, webpage. The reason why the concepts aren't in the framework in this version is that through research, there are so many points that they can't fit into the frame anymore. So you will find them on the homepage. But that actually displays quite well how this framework works with research and is updated and validated through research. Quite central. So caring is more than doing things to people. It's a series of interactions mediated through relationships. The proposed framework is intended to act as a way of encouraging discussion and dialogue around the core elements of providing patient-centered fundamental care. It focuses primarily on how nursing can put the fundamentals of care at the center of its activity. It supports discussions, teaching, practice, and research into fundamental nursing care. It's intended to support nurses in meaningful conversations with colleagues, patients, and health system managers, and leaders about delivering high-quality fundamentals of care. The purpose is not intended to be a comprehensive nursing framework. Some of you, when looking at the framework, might say, well, they're missing this and that. Yes, maybe they do. But that might be because there's not substantial research and evidence to support that this is actually a central element for nurses. And if you think, oh, yes, it is, then this might be the right place to start some research within that field and supplement into the framework. The aim is to put nursing back on the agenda. I teach nursing students half the time. And the first semester, when I greet the students, I usually ask them, what is nursing? Because I think they must know what nursing is. They've applied to School of Nursing, started their education, they imagine what they're going to do in 3.5 years. So I ask them, what is nursing? What do nurses do? What is nursing? Absolute silence, usually. And then if you put up a hand, and then they say, she administers medication. Silence again. And she makes sure they get something to drink and eat. Okay. Then I ask them, do you really need 3.5 years studies to learn those two things? I'm like, no. What that actually mirrors, I think, is that we're not that good as nurses to tell what we do. What are we really good at? What can we do that no other profession can do? We can do a lot, and we don't do them. We can actually kill our patient, can't we? So there's a meaning with nursing. We just have to be better at talking about it. One of the research studies, I looked at nurses' decision-making. How do they decide what to do? And when I talked to them, when I interviewed them, first I observed them and I wrote down what they were doing, and then I interviewed them. And I said, can you tell me a bit about what you did today? What they told me was all the tasks of wounded care. I gave medication. I cleaned a wound. I discharged a patient. I admitted a patient. So what about those 20 minutes you spent with a patient who was in distress, and you actually used quite some time and you used your knowledge within psychology and communication to get this patient to relax? Is that not nursing? Oh, yes, absolutely. Now that you tell me it is, yes, of course it is. But why wasn't that at the top? Why wasn't that central? That has something to do about how we talk about nursing and how other professions talk about nursing. What do the physicians, the doctors require from us? What do they talk about when we speak to them? So, maybe this framework, we don't know it yet, but maybe it can help us to put nursing back on the agenda. Remind us of what is important to patients and nursing. What is it that is required and expected from nurses? Shared understanding. I started out with saying you're here, different nations, different countries. Do you have a shared understanding within your specialty what fundamental nursing care is? Could it be relevant to discuss what it is, to articulate what it is? We have a few nurses and nursing leaders at Aalborg University Hospital who actually use this framework through their working day. Pull out the framework, they take a patient case, and then they reflect using the framework as a reflective tool. And they get the nurses to articulate, to use words on every single element. Sometimes they realize, whoop, we haven't really been about the coping part. And the patient is quite distressed. Should we go around the coping part? That was one thing. They're reminded of maybe we should do something we haven't really focused on. The second thing is, what's the evidence for what we do? This is Alison Kitson. I don't know if you know Professor Alison Kitson, but Professor Alison Kitson started within evidence-based practice and knowledge translation as a focus. How do we get evidence into practice? So all this research in this room, on these posters, how do we get nurses to actually use that? That was one of the things she's looked at for years and researched into. When you think about fundamentals of care with framework, that's also her thought. When you see the word nourishment or hydrated, and you look at the patient you're standing across, what's the best possible form of hydration based on evidence to this patient? We know that research into and development of nursing requires critical thinking and reflection. To reflect on a matter, we need to articulate. So we need to put words on things. If we don't articulate, we don't talk about it, it's quite difficult to reflect among us. That saying, so do we only reflect on the matters that we talk about? And going back to the tasks, do we only reflect about the task-oriented care? And we don't reflect as much on how do we establish a relationship with the patient? How do we communicate? How do we support the patient psychologically? Research shows that we're not that good at articulating those parts of nursing. And when we don't articulate it, it's quite difficult to develop it. So, we need evidence. We need evidence to support nursing. That's why you're here, partly. But that evidence we need to integrate with patient care. And that's where fundamentals of care might be of help, might be one tool to see how do we integrate it. So we don't just focus on mobilization and hydration, but we look at the patient, we think hydration, yes, but first of all, we think about who is this patient? How do I interact with the patient, and how do I integrate hydration with all the other needs that are relevant to look at concerning this patient? So need for evidence, and a need to look at how do we integrate all the needs that are relevant for the individual patient. Thank you for listening.